The idea that neck pain may cause migraine is frequently stated on social media and even among some providers. But is this assertion accurate? Today, we're going to explore this complex relationship and discover that the connection between migraine and neck pain is more bidirectional and nuanced than commonly understood. Before we dive into the details of this lecture, there are three important concepts that I want you to be aware of. This will frame our discussion. First, the fact that migraine is a primary headache disorder. A primary headache is a type of headache that occurs on its own. It's not a result of another medical condition. It's called primary because the headache itself is the main medical problem, rather than it being a symptom of something else, which would then result in a secondary headache. For example, a headache caused by whiplash or an infectious process like meningitis, that would be classified as a secondary headache. So for migraine to be a primary headache, by definition, it cannot be caused by neck pain. This is a critical distinction that forms the foundation of our discussion today. Second is that migraine is a long-term medical condition, so it persists between attacks. So if this is a migraine attack, this is a migraine attack, and this is a migraine attack, what happens in between these migraine attacks? It's still a migraine. This entire thing is kind of like a life cycle of a migraine, with these being migraine attacks. So migraine is a persistent neurological condition. It makes one susceptible to these attacks, and this isn't a new concept. This concept is similar to many other chronic diseases. For example, asthma, rheumatoid arthritis, ulcerative colitis. These are all lifelong diseases that have acute episodes of symptoms. These acute episodes may be triggered by various factors, but the disease itself is generally chronic and has genetic components, same as migraine. So when we are referring to migraine, we are referring to the migraine attacks and the interictal periods, the time in between attacks. A patient has a migraine throughout all of this, not just during the attacks. Third, and to emphasize this as its own distinct point, migraine is a neurological condition that cannot be triggered. It cannot be triggered. Well, you may ask, what do you mean? Of course there are migraine triggers. Yes, migraine attacks can be triggered, but migraine is an inherent condition. Migraine attacks can be triggered by various factors. The distinction between the condition and its episodic manifestations that we talked about here is crucial to understand. This is important for understanding both the pathophysiology and the treatment approach. To understand the relationship between migraine and neck pain, we need to examine the trigeminocervical complex or nucleus, which is located in the brainstem consisting of the midbrain, the pons, and medulla. Now, this complex receives sensory input from the trigeminal nerve. So the trigeminal nerve enters at the level of the pons and then descends, and it also receives sensory input from the upper cervical nerves, creating a convergence in this area that we call the trigeminocervical complex. So sensory is received from the face and the head via the trigeminal nerve. Well, this would be the trigeminal ganglion. And sensory would also be received from the upper cervical nerves, which innervate the neck. Now, this convergence creates a problem for the brain because sensory nerves from both regions converge in this area, and it creates a situation where the brain can't always clearly distinguish the origin of pain signals. So this neural convergence is critical for understanding the referred pain mechanisms we'll discuss and forms the anatomical basis for the bidirectional relationship between migraine and neck pain. So let's look at it a little bit differently to help cement this concept. During a migraine attack, pain signals travel via the trigeminal nerve, again, enters at the level of the pons, descends, and due to the convergence we talked about before, these signals can be misinterpreted by the brain because these signals eventually travel up the brain via the trigeminothalamic tract, or sometimes referred to as the TTT, so that it can be processed, so that it could be quote-unquote felt. However, due to the convergence we discuss with the cervical nerves, and therefore we have our trigeminocervical complex, this creates what we refer to as referred pain. So it's pain in the neck without any actual neck pathology. There is nothing wrong with the neck. There is no neck pathology. So patients feel neck pain even though there's nothing structurally wrong with their neck. There's no musculoskeletal dysfunction. And this referred pain can occur in any phase of a migraine attack, although it is more common during the headache phase. This happens because migraine results in a decrease of inhibition, a lowering of the threshold in the spinal trigeminal nucleus. Therefore, it's more sensitive to incoming signals. Now, you may wonder, well, if it occurs in any phase of a migraine attack, what about prodrome? How does it cause pain during prodrome? Well, this is because in a study using functional MRI scans, researchers observed that the hypothalamus becomes active and functionally coupled with the spinal trigeminal nucleus. Let's go back here. The spinal trigeminal nucleus. The hypothalamus becomes coupled with the STN, and it becomes coupled 24 hours before migraine pain onset. So this early activation means that the threshold for propagating a neural signal has decreased, and this means an action potential can therefore propagate. Now, this neural sensitization explains why neck discomfort can be part of prodrome, occurring even before the headache phase begins. However, keep in mind, prodrome is part of the migraine attack. So when we are talking about neck pain during prodrome, what we are saying is that the migraine attack has already started. This is the X that I drew in the beginning. This would be the space between the X, the interictal period. So what often ends up happening is a patient will experience neck pain during prodrome, and headache develops later, and surmise that it's possible that the neck pain is what had caused the headache or the migraine attack. However, this isn't the case. The migraine attack has already started. The hypothalamus was already activated. The threshold of the STN was already lowered. Prodrome is a migraine attack. The migraine attack has already started. By the time neck pain is felt, the migraine attack has commenced. However, because of its temporal relationship with the headache phase, it's easy to assume that neck pain is the culprit for the actual migraine attack, as if the migraine attack starts here rather than here. Now, when experiencing neck pain, even if it's just referred pain with no underlying pathology, people naturally adopt compensatory behaviors. I mean, we see this in ourselves. If we have bad sleep and our neck hurts, we develop these compensatory responses. We don't hold our head up straight like we usually do. There are differences. And same with neck pain that isn't musculoskeletal, because the pain is still real. The pain is still felt. So, what are these compensatory behaviors or responses? Altered posture. They may alter their posture to avoid pain. Unconsciously holding their head back. Unconsciously holding their head and neck differently to minimize the discomfort. We've all done this with any kind of pain. It doesn't even have to be neck pain. With any type of pain, we move our body differently. We change our posture. Furthermore, we can reflexively tense our neck muscles. This creates unconscious muscle guarding in response to pain. Also, modified movement patterns. This is to protect the perceived painful area, moving differently to avoid triggering that pain, that very real pain. Now, over time, these compensatory responses, they lead to structural changes. They're initially protective. However, they lead to actual physical problems over time. They can cause muscle tension and spasm, resulting in chronically tight muscles from the constant guarding. They create altered biomechanics with changed movement patterns, putting stress on different areas other than normal. They can lead to the development of myofascial trigger points, which are these painful knots in muscles from chronic tension. They also create joint stress and tissue changes from these altered movement patterns, causing abnormal wear on the joints from moving differently. So essentially, these compensatory behaviors, which are completely normal and natural, and obviously we all do, will lead to these structural changes, to these actual pathological physical changes to muscles, joints, and connective tissue. So what began as referred pain, again, very real neck pain, because ultimately no one feels pain until those pain signals head to the brain. It's impossible to feel pain without the pain being sent and being processed in the cortex, whether it's structural or whether it's referred. The only difference between structural and referred is that we can actually quantify structural problems. So what was initially referred pain has now become structural. No underlying neck pathology with actual pathology. So we went from referred pain, compensatory behaviors, to structural problems. Now, once these structural concerns develop in the neck, they have several important consequences that further complicate the relationship between migraine and neck pain. Now we have genuine pain signals. Now, the word genuine here, the pain signals prior were also genuine. The pain signals from referred pain were genuine as well, but this word is used to help you understand that now it's based off of a pathology from affected neck structures. Now, these pain signals, they travel the same exact pathway that had a referred pain. nothing changes. That's why the brain processed it as coming from that area. Still the same electrochemical changes along the neurons in the same neural pathway. Now, these structural changes, because now we have a real pathology, can compress the occipital nerves, resulting in occipital neuralgia. So basically, now we have a sharp shooting pain in the back of the head from irritated occipital nerves. Now, not always, but it can happen. So it's also worth noting that occipital neuralgia is more commonly associated with migraine than with any other headache types, and these conditions are frequently associated with each other. So many times, migraine and occipital neuralgia go hand in hand. So just a quick review, these pain signals from the neck due to pathology enter the trigeminocervical nucleus and then sensitizes the nucleus, making the pain processing center more reactive to all inputs. What does this mean? If the threshold's at negative 55 millivolts, now it can be at negative 60 millivolts. And therefore, it doesn't require as strong of a stimulus to then generate the action potential. That means it's easier for migraine attacks to start. It also makes it easier for other triggers to initiate migraine attacks, as other trigger factors don't need to be as strong to precipitate this migraine attack. However, it's important to emphasize that the neck problem itself isn't causing the migraine condition. It's just that the nervous system has become more vulnerable to triggers due to a decrease in the threshold. Now, this creates a self-perpetuating cycle where the migraine condition leads to migraine attack with referred neck pain, which leads to compensatory behaviors, which leads to the development of actual neck problems, which increases migraine attack susceptibility, which leads to more frequent and severe migraine attacks. Each step in this cycle makes the next more likely, creating this self-perpetuating pattern that needs to be addressed at multiple points to break effectively. Treating neck problems alone or neck pain alone may decrease the susceptibility to migraine attacks, but we need to address what initiated this cycle to begin with, which is the migraine condition, not the neck pain, because it's just going to start over again. However, because this is a cycle, we want to attack it from all angles simultaneously. Therefore, migraine preventives, migraine attack abortives, and pain management strategies and physical therapy are very important. They're all necessary components of treatment once we are caught in this self-perpetuating cycle. Understanding this bidirectional relationship between migraine and neck pain has important implications for treatment. And we've addressed some of this before already, but it requires addressing both conditions simultaneously to finally break the cycle. This means addressing the migraine condition and addressing the neck problems that eventually develop from the migraine condition or may eventually develop. So therefore, we must target the underlying migraine condition. How do we do that? Preventives. Incredibly important. Also, we must address the neck pathology. Addressing the neck pathology here won't do anything because there is no neck pathology. However, that's why we need preventives, because we do not want to get to here when there is actual neck pathology that will need addressing, and therefore neck treatment alone is insufficient. There needs to be better patient education about this complex relationship. Understanding that neck pain can be both a symptom of a migraine attack and a potential trigger for migraine attack helps patients recognize early warning signs and implement appropriate management strategies. It would be great if abortives could be used very, very early on when neck pain is felt in prodrome. Now, the key takeaways from our discussion are that neck pain doesn't cause the migraine condition itself, but the relationship between migraine and neck pain is bidirectional and neurologically complex. The migraine condition often initiates a cycle that leads to genuine neck problems through referred pain and compensatory behaviors. These resulting neck problems can then serve as a trigger for more frequent or severe migraine attacks by sensitizing the trigeminocervical nucleus. Breaking the cycle requires addressing multiple factors simultaneously. With comprehensive treatment targeting both migraine and the resulting neck issues, both conditions can be effectively managed. This approach recognizes that neither condition exists in isolation once this cycle has been established. An effective treatment requires attention to both the primary neurological condition of migraine and the secondary musculoskeletal issues that develop in the neck. And it is only, and I know I'm laboring this point, it is only by addressing both aspects can patients achieve better control of their symptoms and improve their quality of life. Do not expect to treat neck pain to alleviate migraine. Treat neck pain, treat migraine simultaneously for the best possible comprehensive treatment plan.